Ladies and gentlemen, dear colleagues, at the time that I was asked to have this talk, I thought to Emma, not on that day. It's a holiday in Germany, and I missed all the holidays this year. Even for the 1st of May, we had our national meeting, so I was working. And the first day is always the most difficult day, and once you see my disclosure, and you see that we work with different companies, nevertheless, I don't have any stock of any company. And once you start with a JAK, it's not very easy, especially if you start with a mode of action. So I thought I will do it in a different way. And the way is, since we are in Milan, what is Janus? It's the god of the beginning, so we are starting something, but at the same time, it's the god of the ending. You see also the face, and the face looks different. From this side, it's more looking in the future, and this one, gleaning the wisdom from the past. So we can have something from the JAKs known to all of us since many years, but also looking forward what is new that JAK is offering to us. Of course, you see also the picture and you realize, oh, not a lot of things have changed in Italy. You still have work in progress, and even you will see the JAK, the Janus, the statue is still on the same place. But from the artist, the scientists are not very creative. We know this. And once the JAK inhibitors was discovered and the JAK kinase was discovered, it was mentioned this is just another kinase. However, it was not so fancy, so the people move it, and everybody's talking about the JAK inhibition and not about the just another kinase. And why it was like that, you know that the JAK is a family of intracellular non-receptor tyrosine kinase, and then it's very difficult to explain how they in fact works. But you have good friends, and the good friends come from rheumatology. And for the first time, the JAK inhibition was introduced in rheumatology. And you see that it's JAK1, 2, 3, and also the TYK2. And you see on the top, there are different signals which are coming from different molecules, different cytokines. And this is what you know already from the psoriasis and from other diseases. But what's happening once the signal is also coming? What is happening inside of the cell, how these signals are moving, what is important, what is the role of the JAKs, and how do they combine. This is something which was of interest in the last 5 years. Sometimes you are thinking you are playing like a jackpot, because you never know which is combining with what. JAK1 with JAK1, JAK2 with JAK3, and depends on that what kind of combination you might have. If it's JAK1 and JAK3, it also depends what stat is activated. So the specificity is coming. First, which JAK, and the second, which stats. Only if you get the right JAK and you get the right stat, then you had the jackpot. And so if you are playing in Las Vegas or San Diego, you don't have it. And what we also have learned, that learning with this different part of the signaling pathway, that is very important in a different way. You may have an important signal on inflammation. You may have an important signal in, let's say, naive T-cell differentiation or Th17 or inflammation in general. So it depends really on that, what kind of the JAK and what kind of the STAT or TYK2 is inhibited. What are the JAK inhibitors in development for topical treatment of atopic dermatitis? Tofacitinib is known to you. Robert already mentioned the trial. Delgotinib, you know it also as GTE-052. Ruxolitinib, and also the very new one, not in the clinical trials. It is only in a mouse model, momelotinib. I will start with the first one, and the first one is known to you. It's already registered for the treatment of rheumatoid arthritis. It's registered also for the treatment of psoriatic arthritis, but as a systemic drug. That what you see here is the topical use of tofacitinib in a phase 2 trial. And what you see, it is a very clear signal that what you see as a mean reduction of the EASI compared to the baseline. And if you see the numbers, they are remarkable. 80% mean reduction of EASI, which is not bad. And if you go further and look, for example, at the role of tofacitinib on itch, I must agree, easy is not very easy. So you have to know these items if you understand very well from the tofacitinib in the other trials. But you see a very clear signal, which you don't see with vehicle. And this is very important. We see very clear differentiation compared to vehicle. And this is of the particular importance for the trials. Furthermore, if you go the number of the patients who achieve an EASI 50, an EASI 50, almost 80–90% of the patients are achieving an EASI 50. EASI 75 is a little bit more difficult. And then you see that still remarkable high number of the patients are having an EASI 75, showing the capacity of tofacitinib to be a treatment option for the patient with mild to moderate atopic dermatitis or even a moderate to severe. And on the left side, you see the side effects. So from the side effects, you don't really see a clear signal that what you expect from the systemic effect, you don't see it in the topical. And this is advantage of the topical development of the JAKs because you can use it in a dermatologic condition where it's limited for the area where you are using this one. Of course, everybody has a fear. What happens if we treat, for example, topically? How much is absorption? What about the pharmacokinetic of the drug? Because these drugs and all the JAKs may have an immunosuppressive effect, and this is recently published. It depends on the area that you treat, and it is increased with the area that you treat. The tofacitinib concentration is higher on the treated body surface area, but this is relatively large. And to have a comparator, I've put on the left that what's happening if you take, for example, 5 milligram twice daily in children and also in adults, and you see how high the concentration are. So we still have a big margin on the pharmacokinetic point of view. What is the concentration of that what we achieve once we get a systemic drug and once you give it as a topical treatment? So advantages there. Why the company is not developing, we have to ask them. So they are probably in the room. Yeah, I know that some of them are in the room, but they will probably not discuss this. We'll leave it for later. The other way around is, for example, you have a drug. This drug is known, ruxolitinib. It's not approved for atopic dermatitis. It's approved for the myelofibrosis and also polycythemia vera. So it depends from the primary indication, you know what is the potential of the drug. What is inhibiting? It's not primarily that what you will say a very selective JAK inhibitor. And the phase 3 study is ongoing for the graft-versus-host disease. And also, the phase 3 is going also for other indication, becoming very interesting. JAKs are interesting now, not only for atopic dermatitis, but also for other conditions like alopecia areata, vitiligo, and we'll hear a lot about this one. Ruxolitinib has also a very interesting profile. If you look, for example, on a mast cells, and you want to know what's happening, let's say, on a mast cell, and you will realize that, for example, in mast cells, when you inhibit with ruxolitinib in dose-dependent manner, you reduce the production of the substance P. This is probably the way how you understand and you learn how is this inhibiting or preventing the occurrence of itch in this patient. And if you go further and you look, for example, what else is happening in mast cells, it is not very specific. You have also inhibition of TNF-alpha in dose-dependent manner, even in the mast cells. This drug, probably at the very beginning, have been developed not for atopic dermatitis, mainly, as you can see on the profile of the investigation done at the very early beginning. They targeted IL-23, they targeted IL-17, and you may assume that it was more towards the psoriasis, but these cytokines are playing also an important role probably in atopic dermatitis, in the chronic one, and a late stage. So we are learning this is also something which might have effect also in atopic dermatitis, and this data are showing that, okay, it's not only psoriasis, it's not only the diseases which we have known from the past, but it could be atopic dermatitis and a very good target. Knowing the effect on itch, the primary endpoint of ruxolitinib in a phase 2 was to report the effective ruxolitinib cream on pruritus. So pruritus was the main objective because from the previous data, it was shown that it has a very good effect on mast cells and a substance P, and due to that, you expect that in this patient, you will have also the best response. Itch was assessed daily, and you see the patient inclusion-exclusion criteria. This is a patient with mild, moderate, not a patient with a severe, and you see the body surface area limited to 3 to 20%. If you go further and you look, for example, on the patient, you will see that primarily they had a very high itch, but the EASI score and investigator global assessment were more for the mild or moderate form of atopic dermatitis. How are the results? You see also in dose-dependent manner, vehicle is not doing anything, which is always excellent. In atopic dermatitis, last time we had some really different scenarios. And then we see if you compare it, not with tacrolimus, you compare it with triamcinolone acetinoid, and you know that steroids are not having a very good effect on the itch. In this one, very nice, very clear, 1.5 is having a very good response on itch as measured in this clinical trial. If you go further and investigate what's happening on after 4 weeks and after also 8 weeks in the higher dosage, the best response, and you see that also 0.5 is not bad, and then 1.5% cream twice daily had the best and the highest response. Once this patient went to the open label phase, then this patient had also an additional improvement, regardless which kind of the arm they have been treated. And then you see in a period of time of 12 weeks, nice improvement of itch in this patient. Are there any trials ongoing? Yes, there are 2 of them. True, atopic dermatitis 1 and 2, and I just accessed yesterday. So nothing happened, I hope, since yesterday. No new trials. If something else, you have to tell me. Good. And let us move to another one. So another one, it's I will show you the JT052, the phase 1 trial. And what I also like, that placebo is not having any single effect. It's probably easier in this phase 1 if you do a very professionalized sites. You see it very good response and very clear distinction between the vehicle and also the drug which is working. What I also like it in the phase 1, you don't see any big signal. You don't see really something which is for this class, if you treat it systemically, something very typical. If you continue and you look what's happening, this drug is developing very fast. You have seen the phase 1, and suddenly you see now the phase 2 data, and then you see how the patient disposition is. They have also compared directly with tacrolimus and also placebo. A very nice to have an active comparator, to have a placebo control, and also different dosages. So typical design of a phase 2A, where you know from the beginning, oh, this will lead us to probably better knowledge of that, what is happening in the future. Let me show you the results. These results were presented at the, the other one was presented at the American Academy. And then you see that it's very similar to that what we see with tacrolimus on the higher dosage, but 0.5 seems to be in a very good one. There were no big differences. Since there are small studies, you don't see also the big differences. 0.5 is crystallizing to be in a very interesting dosage on a phase 2, and especially if you go, for example, on itch, and you carefully look on itch what's happening, then you see the high dosage is having a biggest impact on a daytime itch, but also 0.5 is not bad. It's even better than tacrolimus. Or the nighttime itch, also there, much better at the beginning than, for example, tacrolimus. Having this knowledge on how good it is on itch, it could be a very good treatment option for our patient in the future. And you do the trial also in adults. What was interesting, we don't see any dose-related adverse event. Adverse event associated with skin infection, mentioned also earlier, that could happen, that were not observed in this early phase 2. And immunosuppressive activity is probably there. We have to observe. We'll see what's happening on the phase 3, in the larger phase 3 trials. But you don't need to wait. They have done even a pediatric study in Japanese patient. This was a patient who were having more moderate to severe form of atopic dermatitis, the body surface area 5 to 30%, an EASI score more than 5, so it's a more moderate. And you see they have compared vehicle, delgotinib, in 2 different dosages, where 0.5 is considered that one which will be developed in children, and also after screening, the patient was treated for 4 weeks. That's what you see now, the mean EASI score, 61% improvement of the mean score in the first 4 weeks. And if you go further and go more in depth and look for the EASI 50, very nice response, 60%. EASI 75, the half of the patient in a short period of time of only 4 weeks are achieving an EASI 75 in the population which is more moderate, not very severe, but a moderate one, which I think it's a very remarkable results in this group of the patient. Moving further, and now you see Japanese pediatric, the safety adverse event. No big differences. There's more frequent nasopharyngitis. We don't know why. It could be that the patient are longer in the trial. It could be due to other reasons, immunosuppression or anything else. But that's what you typically see by the JAK systemically. You don't see it in the topical treatment. Moving forward is also the phase 3, also recently presented at the American Academy a few months ago. In the phase 3, it's a Japanese adult patient. These were patients with more moderate to severe form. Patients who have also body surface area of approximately 23. You see that about 1/3 of these patients are having also investigated global assessment as a severe one. In average, an EASI score of 40-50, so it's more severe. And of course, if you have the population like this, you'll expect the big difference between placebo and also the drug. And then you see 44% of the patient in a period of time of the 4 weeks achieving a mean EASI decrease of 44 compared to the baseline. And now you for sure want to know about the EASI 50. EASI 50 was also not bad, not as good as in children, not as good as in mild to moderate, but still 50% of the patient in 4 weeks are having an EASI 50. And the EASI 75 is also not bad for a short period of time. Patients who have a topical treatment only, where you have an EASI 75 in approximately 1/4 of the patient. What is also very encouraging, if you see the safety profile, there are a small group of the patient, but still you don't see any difference, any new signal, which was not shown in the past on the phase 1 and also on the phase 2. With this, I'm coming to the summary of my talk. And I think that there's growing evidence that oral, but also topical JAK inhibitors may be an effective treatment alternative for our patient. And ruxolitinib ointment is probably effective in itch, but it could be it's effective also in atopic dermatitis. Delgotinib ointment significantly improved all signs and symptoms of atopic dermatitis, including also itch, and it's in development in a phase 3, and it's having a very good chances to get further. Both of the drugs were well tolerated, and the future studies of topical treatment targeting JAK and STAT will probably come more and more, and we will see more and we'll hear more about this very promising target for our patient with mild to moderate, but also moderate to severe form of atopic dermatitis. And summer is coming not only in Italy, it's also coming in the north of Germany. The most important is from which side the wind is coming. And then if we have a power, then probably this is very important for the development of the JAKs. So thank you very much for your attention.